Well, as we know that BRS has lately been in some controversies because of the follow-up data showing that there are some issues regarding stent thrombosis. Not huge, but clearly significantly more than the new generation chromium cobalt lima stents. So I think it's very topical to talk about how to have the best possible results with BRS, because BRS technology is a very intuitively a very attractive technology, because it makes sense that the stent, after completing its scaffolding function, should not be there, and it should be the area which was stented should be a normal vascular structure, endothelium should be normal. So some of the things: number one, the absorption has to be time dependent. Lately it is being felt that the absorption should not be very slow, at the same time it should not be very rapid. We have learned the lessons from the first generation magnesium stent, which used to get absorbed within a few months. That was in the non-drug era, and the restenosis rate of that stent was close to the restenosis rate of the balloon angioplasty, 30 to 40%. And then we have now the PLA stents and also modified magnesium stent, which is now slower in absorption. That stent gets absorbed in about a year, and the stents which we are going to talk about, made out of polylactic acid polymers, take at least 2 to 3 years to get totally dissolved. One of the issues with the scaffolds have been that they are bulky. If you talk about the first bioabsorbable stent, which is about, we used to hear about it about 15-20 years ago, much before we talked about Absorb and the other stents, was the Igaki Tamai stent from Japan, and I think 20 to 25 such stents were used. But that time also one of the issues was it was very difficult to deploy. It was 170 millimicrons in diameter, in the strut thickness. And then came the Absorb, Dissolve, Resolve, many stents, but they're all more than 100, 120 millimicrons. So whenever a stent has this kind of a strut thickness, obviously it is going to be difficult to deploy, and we who are used to these days deploying metal stents which are very low in strut thickness, 60, 70, 50, find it difficult and different. Their use is different and their techniques have to be a little different. First of all, we need a very good support. The guiding support is extremely important, so that we have coaxial support and we can go through that without much difficulty. Radial sheath should at least be 6 French, but if you are thinking of a bifurcation lesion or this thing, maybe a 7 French. Lesion preparation is extremely important, and that is one of the very important parts of the PSP, that prepare the lesion very well. Unlike the metal stents where a half prepared lesion is okay, because once we put in the metal stent we can go on increasing the size of the balloons by 0.5, 1, sometimes even 2 millimeter, but that is not possible in a BRS. And then the implantation technique. Now the guiding catheter has to be chosen depending upon the anatomy. Some people like to use a Emplas catheter, most of us in the left system use a XB or extra backup support. And 6 or 7 French depending upon your ease, your comfort. And the guiding catheter has to be of a variety which it doesn't kink. And some of the catheters, most of them have hydrophilic coatings for enhanced catheter trackability. And sometimes we need to use, in addition to guiding support, something like a guideliner if the stent is getting difficult to get along the turns and bends of the vessel, so a guideliner has to be used. So prepare the lesion very well. Pre-dilatation with a properly sized balloon is important. If you are thinking that you have to put in a 3 mm scaffold, go up to 3, so that once you put in the scaffold, the vessel is already opened to the size of the scaffold. And this should be done with a non-compliant balloon, because otherwise there can be a dog boning effect and the segment may not be dilated so well. Some of the edges might be dilated more than the lesion itself. And if the lesion is calcified or the balloon is not opening fully, having difficulty, one should never hesitate in debulking. One could use sometimes a cutting balloon, but in a calcified lesion, the debulking by rotablator is one of the most effective ways of preparing the bed very well for deploying the stent. And intravascular imaging has again an important role. It not only tells you about the structure of the endothelium there, but also gives a very good very good idea, very good visualization of the diameter which is required. The reference vessel diameter can be very elegantly and reliably ascertained by using a OCT technique. Now let me give you a very interesting case example. And this is a young female who was a hypertensive and had lupus. And as you know, patients with connective tissue disorders, atherosclerotic process can occur a decade earlier. She had a vaginal delivery of a preterm baby 3 to 4 months back. She was a smoker, and she had been complaining of chest pain intermittently, with the ECG showing changes in the anterior leads. Echography which was done showed some apical hypokinesia. Pericardium was normal, there was no fluid there, and troponins were positive, indicating that it was a acute coronary syndrome. And this is the angiographic picture. As you can see, there's a mid-LAD stenosis. There's a haziness in the lesion, as you can see in the right upper panel, and the right lower panel very clearly shows you a very significant stenosis in the mid-LAD, just close to the septal. The strategy which was proposed, first of all, was that let's do an OCT before dilating this lesion to characterize the lesion, because it's a young post-pregnancy female, whether this is spontaneous dissection, and in the dissection there might be a vessel hematoma. So it will be good to visualize the vessel by OCT to also try to find out what exactly is the etiology of this narrowing. And then one can do a balloon inflation pre-stenting before the BVS would be implanted by a non-compliant balloon. So what are the appropriate indications of BVS? Number one, a young patient, because a young patient, it makes sense that the stent, after deploying and completing its function of scaffolding, does not need to be there. Maybe diabetic patients and lesions in segments, patients with diffuse disease where you might use multiple stents, and later after many years the patient might require a bypass surgery. In that situation, if there is a full metal jacket, it is not appropriate because it will be very difficult for the surgeon to put in a graft because it will be all metal. So very long lesions, diffuse disease, is also a good indication for the BVS, and especially if the vessel size is 2.5 or more than 2.5. So this is an optimal indication. Patients where there is no potential benefit, where the lifespan is limited because of multiple problems, multiple other comorbidities, where you don't think the patient is going to make it for more than a few years. Patients who have come very sick in cardiogenic shock, severe heart failure, very low ejection fraction. Those are the patients where I think the utility of the long-term benefits of this particular technology are going to be very marginal and limited. So I think they may not be the best cases. Now this is the OCT before doing angioplasty of this young lady, which shows that there is severe stenosis, as you can see on the right side panel, the stenosis area of about 1.2 millimeters. And you can see the distal LAD is 2.85 millimeters and looks free of disease, and the proximal LAD is 3.35 millimeters. You can see that there is a difference in the vessel diameters in the proximal and distal, and we know that vessels taper. Now after doing a balloon pre-dilatation, a 3.18 millimeter stent BVS has been implanted at 18 atmospheres, and as you can see angiographically on the right panel, it looks really reasonably okay. But if you see the left panels, especially the lower panel, you will see that the stent is not fully deployed. This arrow shows you that there is a gap between the vessel wall and the stent struts. The stent area is coming to around 5.05 millimeters. So this has been post-dilated. 3 millimeter has been post-dilated with a 3.25 millimeter balloon at high atmosphere, a short balloon, so that the balloon remains within the stent. And as you can see, angiographically is the same, but here you can see the diameter has increased to 5.29, but still you can see there are some regions where the stent is not fully apposed. So now we have gone with a non-compliant balloon 3.5 millimeter going to 20 atmospheres, and you can see that angiographic result, which anyway looked okay, remains the same. But then you can see in the OCT the area has increased to 6.29, although there is some asymmetric stent expansion, because if the vessel has fibrotic areas and the rigidity in some of the portion, the stent is not going to expand as a circle. It may be expanding as an oblong structure. And now you can see the same patient, 1 year follow-up, and you can see a OCT pullback, and you can see that the stent is enveloped with endothelial tissue. It is well embedded there. It is still there. We can see, and this is coming to the proximal vessel. We'll show you again. See it again. This is the distal to proximal, and you can see the stent struts, which are well covered with the endothelium, and all the stent struts are covered, and this is the proximal vessel. So this is a 1 year result, indicating a good result. So when we deploy a BRS, unlike a metal stent, we can straight away usually go to the high pressure. It is because we should always remember that it is a plastic. So one goes slowly. The inflations typically should be 2 atmospheres to 3 atmospheres every 5 seconds, till the time you go to the nominal pressure of that particular stent, which is usually 10 or 12 atmospheres. And then a prolonged inflation of 30 seconds at maximal pressure. Intravascular imaging is desirable, especially in the early experience of an operator. Later, because of his or her own experience, you know that all the scaffolds have to be post-dilated, and post-dilatation again is into limits. You can't expand a 3 millimeter stent to a 4 millimeter stent. You can at the most go by 0.5 millimeter balloon, which is larger than the BVS. So that one goes systematically. And the other thing is, since the vascular scaffold is fluoroscopically not visible, it's very important to look at the markers. And so that whenever you post dilate, your dilating balloon is within the markers. Now the meta-analysis have shown that subacute thrombosis is reduced significantly if one does intravascular ultrasound or OCT, and also uses a post-dilatation, systematic post-dilatation, looking at the stent by intravascular imaging technique, making sure that the stent struts are very well opposed to the vessel wall. Now for long lesions where you require more than one stent, in that situation we have to be very careful, much more careful than what we do in the metal stents, because the portion of overlap, if there's a overlap, if the strut thickness is thick, then there will be two layers of the stent, and that would indicate that the strut thickness at that point is double. That is, if it is 120, 130 milligrams, it becomes 230 millimicrons. And this is how it is done. Now the stent marker in all the vascular scaffolds is radio opaque, and the balloon also has a marker. So one makes sure that the stent marker of the distal stent, and when you put in a proximal stent, the stent markers and the stent markers of the proximal stent don't overlap. So because there is a portion of stent about 1 millimeter or 1.2 millimeters distal to the stent markers or proximal to the stent markers, so one keeps the balloon marker close to the stent marker, just close to it, not overlapping it, so that the 1 millimeter or 1.2 millimeter portion of the BRS of the proximal stent is not overlapping actually the distal stent. Now coming to the thrombosis, once again deploying these stents in a situation of ST elevation myocardial infarction, there is a higher chance of stent thrombosis. Similarly, in longer lesions, there is a higher chance of stent thrombosis as per the meta-analysis of studies taking more than 2,600 patients. Bifurcation lesion, although it has been done, but is not a perfect indication, is not a good indication, especially if the side branch needs to be intervened. So provisional crossover of one scaffold is preferable, and two stent techniques, number one, are challenging, time consuming, resource consuming, and intravascular imaging is absolutely essential. So I think at present one should avoid using bioresorbable scaffold in the side branch, and if one can get a good result with just a balloon in the side branch is good. On the in those situations where a dissection or something occurs and you need to cover that, I think a metal stent would be preferable. Lesions selection, as I already told you, is very important. One should avoid highly calcified lesions. One should avoid lesions which are very tortuous. Left main, still we don't have stents of 5 millimeters, and because left mains are large, usually very large. A major bifurcation with a side branch which needs intervention is not a good lesion. And a restenotic lesion, although people have done angioplasty using BRS and restenotic lesion, but we have hardly any data, systematic data on that. So I would suggest that that should also be not a case to be selected. And saphenous venous grafts or internal mammary grafts, this again is not a recommended target for a BVS. Procedural recommendation which we go on talking, very good predilatation, that is the first P, is very important, and one must go up to the size with non-compliant balloons, which is the actual size of the scaffold which you are using, and one should be very, very careful in measuring the vessel size before taking a scaffold and deploying it, because once you have taken a smaller scaffold in a larger vessel, it's very difficult to make it larger than 0.5 millimeters. And after deploying the stent, post dilatation is extremely important, and you first go with a 1/4 millimeter balloon, which is more than the stent diameter. Like 3 millimeter stent, you should go with a 3.25, and then maybe up to 3.5. And at the end of it, using an OCT is very reassuring, because as I showed you in the example, the angiography has limitations. It shows that it's well deployed, narrowing is not there, but when you see OCT, and if you don't do a post dilatation, you will always see that there are some struts which are not opposed, and that is the sign of a problem which can come in the short term. So after post dilatation, and when you are, think that the complete result has been achieved, you always do a OCT, especially in the beginning. But the experienced operators always post dilate with a balloon which is 0.5 millimeters at least bigger than the stent which was deployed. So these are once again the 4 PSPs: prepare the lesion, properly size the vessel, pay attention to the expansion limits, and post dilate with non-compliant balloon at high pressure. Now you can see this is the stent which has the most experience in the published literature, and the long-term follow-up studies of this particular stent Absorb have shown that stent thrombosis can be a problem in up to 2 to 2.5% of cases. And this is the stent Maris 100, which is an Indian stent, which we call as the new generation or second generation stent. It has reduced strut thickness. Because of reduction of the strut thickness, the deliverability is easy, and a number of sizes available are much more than what we have in Absorb, and it has ability to treat lesions across the spectrum. Now, it is a very peculiar design. It has got closed cells at the edges and open cells in the center. This makes it a very novel scaffold architecture, giving it low strut thickness and a low profile delivery system, giving it a very good radial strength. The radio opacity of markers that you can see is a couplet of markers, 3 of them, which gives it a 3-dimensional picture, 3-dimensional view, and you can actually see them very well, and they're very useful when you are post-dilating the stent with a high-pressure balloon, bigger balloon, you know where you are. And if you have to use another stent, you can see the edges of the stent very well, because as I told you, the edge of the stent is about 1 millimeter away from these markers. In proximal, there will be little more, about 1 millimeter of the scaffold protruding proximal to it, and distally 1 millimeter of the scaffold protruding distal to it. The architecture allows you good crossing of the struts, and it has a long shelf life. It doesn't have to be kept in any particular temperatures, and has got a very predictable degradation profile. So we have already done the first-in-man study with 108 cases, and the follow-up results have been very good. The clinical follow-up, as well as a subset had OCTs and a subset had IVUS, and the areas seen have been very good. They were all simple lesions. Only 2 sizes were available, 19 and 28, and the results in this need to be confirmed in larger studies. And right now, Maris Extend is going on in some countries, Southeast Asian countries, and also in Brazil. I think the recruitment is almost complete. And then large registries which are going to be starting in China, India, and international. They're going to tell us the actual clinical utility. So today's commercially available BRS, I must say, need a more meticulous implantation technique. We should always start our experience with simple lesions, assistance of an intravascular imaging system is very useful, especially in the beginning. Late clinical results compared to current DES need to be demonstrated. We need to show that in terms of safety, they are equivalent to the new generation metal stents. And finally, we also need to see, following 3 to 4 years, that the promise of the BRS is there. That means the vasomotion studies, exercise capacity of the person is better than the usual metal stents. All this needs to be proven. Hypothesis is there, and intuitively they should be better, but we need to be watchful, careful, and see how we go about it. Thank you very much.
Thank you. So, Upendra, again, a lot of insightful information, as always. I have to ask you a difficult question. So recently, in the United States, as you know, with the Absorb 3 data being presented at the American College of Cardiology, also a FDA warning letter that came out suggesting perhaps some pullback of the current BRS Abbott technology in the United States. And I was at a recent advisory board for Abbott Vascular on BRS technology. What would be your advice to companies and physicians on the future of this technology as it pertains to what we're going to be doing in the next 10 years for coronary application?
Yes. One thing is very clear, that reducing the strut thickness is going to be difficult, because basically it needs PLLA stents need a scaffold, need a particular rigidity, need a particular wall stress, and they should not recoil. So that, like Maris is 100, 110, it looks good. We need to be careful and watch about its long-term effects. And also the PSP is extremely important, because in the studies with the follow-up where the stent thrombosis has been an issue, PSP has not been systematically done. And including the IDA study, which got released only, I think, 2 or 3 weeks ago, in which the stent thrombosis was 2.5. In the initial part, the PSP was not being adhered to. And the other important thing is the question of dual antiplatelet therapy, which is extremely important. When we first, talked about BRS and visualized it, it was thought that one of the good things would be that possibly the dual antiplatelet therapy would not be required for a very long period of time. But now it is very clear, with this late stent thrombosis coming, that we must give dual antiplatelet therapy till the time the stent completely gets reabsorbed. It could be 2 years, it could be 3 years, because I don't think the present generation stents get absorbed up to 3 years. And the other important lesson, I think, what I am told, that Absorb 4, in which PSP is a must, compulsory in all the patients. The stent thrombosis rate, although we don't know, they have not been blinded by the Data Safety Monitoring Board, in both the arms, it's less than 1%. Even if all the stent thrombosis is happening in the BVS arm, still the stent thrombosis rate seems to be much lower. So I think in this technology at present, we have to be extremely careful about the deployment technique. And although there are other school of thought feels that the degradation product of the BRS, which ultimately is carbon dioxide and water, but it may go through some stages in which proteoglycan comes out, and proteoglycan is a very thrombogenic substance, and that can also be a reason of stent thrombosis in patients where everything else was very good. So I think dual antiplatelet therapy is critical in these patients, and that is, I think, to be emphasized. And also the preparation, proper sizing, post dilatation, extremely important. And if one can do intravascular imaging in as many patients as possible, and wherever you are in doubt, please do it. It should be done, because this is a technology which has to be respected, and it should not, prematurely be killed by these kind of reports. So I think one has to be careful, and like a baby, it has to be nurtured, because
Upendra,
the
thank you very
future
much.
and intuitively it looks so good.
Great. Thank you. Any questions from the audience for Dr. Kaul? Okay, we're going to bid you goodbye. I know you have other procedures to do. Thank you very much for your time.
Okay.
We'll see you very
Thank
soon.
you. Thank you. Thank you. Bye-bye.